Okay, so part two is postpartum infections. It will be a little bit quicker than postpartum hemorrhage. Um, Childbed fever used to claim the lives of a lot of women, especially back in the days of Semmelweis when medical professionals used to go from dissecting cadavers straight to taking care of postpartum women. Um, but they are common enough that we should know how to deal with them, even in today's aseptic age. It's amazing how many more we don't have, considering how much bacteria there is in the birth canal and how much disruption takes place in that area. But we do still see a significant number of women return for care with an infection. So, sites and sources of infection we have inside the womb or endometritis, inside the uterus. There are urinary tract infections, wound infections, and mastitis. Infections can progress to sepsis. They seldom do, but with adequate treatment, but they can. So we want to be vigilant. The onset is usually at home. And so that's why we want to be so careful with those post birth warning signs in our discharge education. Signs and symptoms of endometritis: foul smelling lochia. Obviously, anytime something that comes out of the body smells bad, we suspect that an organism is doing something nasty. Temperature of 100.4 or greater, usually it'll go up to about 101 or upwards. Tachycardia, that happens with your temperature. Chills and aching, also a sign of fever. And then you have lower abdominal pain. And if you were to assess that woman's uterus, she would complain of tenderness when you assessed her. So it's an infection of the uterine cavity. It's most common in post cesareans because you're surgically you're creating a portal, a big portal of infection. You're putting foreign objects. And even though we try to be very strictly sterile and we monitor that sterile field, we are like breaching that sterile cavity. Now, this is sort of interesting because I think your book is a little bit behind. It says 10% or less who are treated with a preoperative antibiotic will acquire an infection. And I believe that statistic is probably accurate. 35% if not treated prophylactically. And then your book goes on to say that most women are not. We've been doing pre-op antibiotics. Usually it's Ancef unless they're allergic, and then we can give a different agent. But we've been doing that for years, and it's part of our SCIP protocol, and it has to happen within an hour of first cut. If it's longer, then they have to be treated again. Other risk factors, aside from cesarean, anybody whose membranes were ruptured for a super long period of time, particularly if they were examined multiple times in labor. The vag exams tend to be the big predictor of that. And people with compromised health status or lower socioeconomic status are also at risk. Remember, we talked in class a little bit about women who can't afford pads. It's almost like an unnecessary expense. They may not be able to perform proper hygiene or change their pads. Instrumental deliveries because they cause more disruption to the area, and there's insertion of a foreign object in the vagina that kind of goes like it can create that ascending pathway. The way we treat it depends on what causes it. So you do endometrial cultures, or you don't, but the provider will. But it takes 2 or 3 days to come back. So usually they'll start the person on a cephalosporin or penicillin unless they're allergic to it, in which case they'll use a broad spectrum agent. And then when they get the sensitivity back, they can fine tune it. But we're going to give IV antibiotics for endometritis until the patient has not had a fever for 24 hours. Now, if they get a more aggressive infection, if it progresses to parametritis or peritonitis, you give the big guns, vancomycin, gentamicin, Clinda, usually in combination. Vanco is one of those drugs that kills mostly everything, but it's also sort of harder to tolerate and can lead to significant side effects. So, we start with the cephalosporins or penicillins unless it's a really aggressive. And most women do recover from an endometritis and they don't go on to have any long-term complications. That word sequelae is fancy for long-term complications. The next type of infection we might see is urinary tract infection, are actually very common. And I think the statistic on asymptomatic bacteriuria, which sometimes progresses to UTI, is like 40%. It's very, very high. But risk factors, we catheterize a lot of women during labor, sometimes after labor, if we want to prevent a postpartum hemorrhage. Urinary stasis. So anytime a woman is retaining urine, whether because they can't void or because they wait too long, they have visitors and they don't want to get up to the bathroom, or they're breastfeeding and then somebody comes in and then they get a dinner tray, whatever. So urinary stasis is another one. That's why we teach our patients, make sure you're voiding every 2 to 3 hours. Then we have, most births include some minor trauma to urinary structures like the bladder or the urethra. But one of the biggest culprits is improper hygiene. And this is another place where your teaching comes in. Always front to back, use the peri bottle. I try to discourage women from rubbing with toilet paper, because the pieces of toilet paper can sort of tear off and stay behind and leave like a little wick where infection can start. So change your pad every 2 to 3 hours. If you're going to use toilet paper instead of those soft wipey cloths, then pat dry, don't rub. They don't want to rub anyway, it hurts if it's a vaginal delivery. So we didn't really talk about this too much in the last video. These are tips you can use with anybody who's got some urinary retention. And they're sort of good nursing interventions. You don't need a doctor's order to do any of them. Number one, you've got to manage pain. So if a woman is in pain in her urethral area, she may retain urine because it hurts, it stings. So that's where we can use the squirt bottle, we can use the Tux pads, we can use ice to prevent edema, and we can use the numbing spray, the Dermaplast spray. You can pour warm water over the genital region to sort of get things flowing. Use that peri bottle to sort of get things started. Having the woman lean forward puts a little pressure on that bladder, so that's helpful. You can run water because the power of suggestion. I couldn't watch the Titanic when I was pregnant with my oldest daughter because I was afraid that looking at all that ocean was going to make me want to pee. You can use that to your advantage by running the faucet. This one I've never used, having the woman blow bubbles through a straw, like you give her a cup of water and a straw and you tell her to blow bubbles. Allegedly, it relaxes the pelvic floor enough that she can release the urine. And peppermint oil. This is sort of a new, maybe it's not that new, but it's new to me. We started using this. I don't know why it works, but it does seem to work. You put a little bit in the hat or the bedpan, or you can put a little bit on a piece of toilet paper and let them kind of smell it, and that seems to help them let down. Management of UTIs, again, most of the time this happens at home. So teach the woman signs and symptoms of a UTI. Burning, urgency, frequency, same as you would in a med-surg patient. Nocturia, she's getting up in the middle of the night to pee. If a UTI progresses, she's going to start having fever, chills, flank pain, because now it's pyelonephritis, it's in the kidney. She might get nausea, vomiting, and the fever sometimes goes way up to like 104. CVA, or costovertebral angle tenderness, is something that a provider can assess. You probably learned this technique when you were in health assessment. I know I taught it in the lab in health assessment. And that's, you put the palm of your hand over the flank, right at that angle where the rib cage meets the backbone, like the lower rib cage, and you kind of percuss over your hand a little bit. It's not, you're not punching them, but you're just kind of doing that dull thud. If they like yelp in pain, then you're looking at a pyelonephritis. And you can diagnose a UTI, of course, with a clean catch specimen. It does take a few days to come back as far as a culture and sensitivity, but you'll right away get leukocytes and sometimes bacteria and protein in the urine. Management of UTIs is, of course, antibiotics. Bactrim, this is not a case for cranberry juice. You need to get this woman comfortable. Bactrim is a combination drug. It's like trimethyl, I can't even say the word, so I just put Bactrim. I won't test on the names of those drugs just because I didn't provide them. So Bactrim and Septra, and nitrofurantoin, which is also known as macrobid, is a very common agent in the treatment of UTI. Other sulfonamides might be used. Augmentin, which is penicillin with an additive. You guys have taken pharm. I'm not going to beat that to death. And when you have pyelonephritis, when that woman comes in with that 104 fever and the chills and the nausea and vomiting, and she's got the CVA tenderness, you're going to want to give IV antibiotics. And usually it is like a Clinda, Vanco kind of thing. You want to like knock it out quick. We give antipyretics. Those are your anti-fevers, acetaminophen, ibuprofen. They will also help with pain. Sometimes you'll have to give something stronger. And you can give an antispasmodic. Pyridium is the name of a drug that stops bladder spasms, and that can be helpful. We're moving on to wound infections now, and these have been very common. I think with the obesity epidemic, we're seeing a lot more wound infections, and it's miserable for the woman who has them. So it's absolutely critical to teach women how to assess their wounds and how to care for them properly. Risk factors, obesity, definitely. Think about it. What does bacteria like? It likes warm, dark, and moist. Where do you put that incision? In the low bikini area right over the pubic line. What covers the pubic area? Well, a big belly. Especially if it's already distended from being postpartum. We know that women don't go right back to their flat stomachs right after delivery. It takes about 4 weeks or so. Staples have been implicated as a factor in wound infection because in addition to the primary incision, you now have at each staple 2 more portals for infection. Compromised health status. So women who are anemic, women who have diabetes or any kind of altered glucose metabolism, women who have had a hemorrhage, anybody who's got compromised health status is at risk for wound infection. Lower socioeconomic status, for probably similar reasons, more compromised health status, and also with lower socioeconomic status, we sometimes see poor nutrition, and nutrition helps wound healing. The longer that wound stays open and takes to heal, the more of a chance of infection. And poor hygiene. So women who don't shower every day, women who take tub baths with their C-sections, women who use the towel that everybody else in the family is using, these are women at risk. So signs and symptoms: redness, foul smelling discharge, edema. Induration means hardness, so that incisional area will get hard, um, and pain. More pain than you would expect. The most likely culprit is usually Staph aureus. It can be MRSA, so we have to be careful. Treatment: we're going to culture it. We're going to find out what caused it. And we're going to give antibiotics that are specific to that organism. Now, while you're waiting for that result to come, it does take about 2 to 3 days to grow the buggies. You're going to use the agents that target Staph aureus because it is the most common one. So usually we're looking at penicillins and cephalosporins, things like that. Now, if you see pus or there's a collection of fluid underneath, a lot of times what the provider will do is they'll rip open the stitches and leave it open with packing. And you might have to do a wet to damp dressing, and teach the woman to do wound care at home. And this can go on for months. One of the worst cases I can recall, we had a housekeeper who worked for us, and she delivered her baby with us, had a C-section after many days of labor, was 379 pounds, came back with a raging wound infection. They opened it up, they packed it. It took her 4 months to heal, and she had a wound back. And that was miserable. She was taking care of a newborn all this time. So, we really can't stress enough prevention. And then pain relief. Obviously, if you have an infection, antibiotics will eventually kick in and you'll feel better. But in the meantime, you need to give this person adequate pain relief. Next infection we're going to talk about, and it's the last infection we're going to talk about, is mastitis. Mastitis, obviously, is an infection of the breast. It's more common in nursing mothers. The vast majority, 97 to 98%, are people who are breastfeeding. And risk factors for this: cracked nipples create that portal for infection. They just descend right through the milk ducts. Compromised health status, so people who are anemic, people who have diabetes because there's more sugar. Antibiotic therapy leads to yeast infections. It won't usually lead to the ones that cause staph. Like, it won't give you the ones that have, like the abscess, but it will give you yeast infection. So a woman who was treated for GBS and she was in labor for, ever, we should be alert to that possibility. And the biggest culprit with a lot of women is milk stasis. So inconsistent nursing or pumping schedules. So maybe they're pumping, nursing, and they have this fabulous milk supply that everyone is jealous of. And then all of a sudden they just don't nurse for a day and they don't pump. That milk stays where it is. It can create little crystals or, kind of solidifies inside the duct. It's full of sugar. It can't be expressed. And so you have like this little perfect petri dish. So that's like maybe one of the biggest culprits. Signs and symptoms, it'll start with a plug duct, which is not an infection, but it looks like a red lump in the breast and it's superficial. If you can get mom to resolve the plug duct by massaging from that lump towards the nipple, pumping, using heat or whatever to get that milk flowing, that's helpful. If it progresses to an infection, you're going to see fever, chills, and just generally feeling unwell. They feel like they have a mild case of the flu and they have pain, breast pain. Now, yeast infections are a little different. You don't see that red lump in the breast. What you see is these bright pink nipples, and women will describe the sensation of nursing their babies as ground glass in the nipples. Ouch. It is incredibly painful, and if we don't treat mom and baby, they're going to keep passing it back and forth to each other, and that's not good. An abscess, when your mastitis progresses, you can see that collection of pus. Sometimes it gets almost like a black and blue appearance. It's very, very, very painful, and it usually needs to be incised and drained. So, treatment of mastitis. Under no circumstances should this woman stop breastfeeding or expressing milk. That compounds the problem. That makes more milk stasis, more grounds for bacteria. She may get infections in other areas of either breast. If she can't nurse the baby, if it hurts too much, pump, express, pump and dump, using heat and massage to encourage that milk expression right before she nurses. She can use ice in between to relieve pain, but right before she goes to express that breast, which should happen every 2 to 3 hours, like clockwork, she should be using some heat and massage from the chest wall down towards the nipple. Antibiotics, you can use cephalosporins like Keflex. For yeast, you use diflucan and use it actually in much higher doses than you would use for like a vaginal yeast infection. Sometimes the insurance companies seem to have a problem with that. And if it's an abscess, we're going to do incision and drainage. If it's really bad, she might need to stay in the hospital and get IV antibiotics. And that is video 2.